Good morning, everyone. Thank you for joining us here today. I'd like to welcome members to the first Health and Wellbeing Board meeting of the municipal year. This is my first meeting as chair, so forgive me any faux pas. If I don't see your hands up on the screen, because I'm not very good at working two ways here, just shout or Darren will look out for me. I'd like to take this opportunity to thank Councillor James Holden for the invaluable contribution he made to the board during his time as chair, and I'd like to thank Councillor Kent for his contributions as a member of the board. Welcome Councillor Ralph. I don't know if it's Councillor Maldoni online. She's not attending today. No. Haven't got any apologies for her. No. And Councillor Lydiard for continuing your allegiance to the Health and Wellbeing Board and your contribution. I've received apologies from Councillor Johnson, Julie Rogers, Pretty Sood, Michelle Stapleton and Sheila Murphy. Does anybody else have any apologies they want to recorded?
Chair, can I just give the apologies of Anthony McKeever from Mid and South Essex Health Partnership?
Thank you. Yeah, thank you.
Chair, could I also give apologies for Jill Burns for the Children's Services at NELFT, and I'll be representing Jill's Children's Services today as well.
Lovely, thank you very much. And I understand Temporary Chief Inspector Terry Fish will be representing Essex Police and will be attending virtually. Yeah, are you with us? Yeah.
Indeed, and good morning, I am here.
Morning. Welcome to members and colleagues in the room, not many of us. While I'm sort of on that point, to officers as well, I know we've had apologies from some, but if we can start to join in the room, because we had a little conversation this morning about making sure we're quora in the room as well, if possible. So if we move on now to agenda item number 2, any urgent items of business. I've not received any urgent items in advance of the meeting. Does anybody have anything? No. Agenda item number 3, declaration of interest. Do any members attending today's meeting wish to make any declarations of interest? No. What's this? Moving on fast then. Agenda item 4, minutes of the meeting from the 12th of December. Minutes from... minutes and actions arising from the 18th of March, not December. Are members content that the minutes provided at page 5 of your papers are an accurate record and you're happy? I'll take the silence as a yes. Agenda item 5, the annual review of the terms of reference. So moving on to number 5, the annual review of the board's terms of reference, a covering report and supporting documentation is provided at page 13 of your papers. I'd like to ask Darren to introduce this, please.
Thank you. Thank you very much, Chair. Just to update members that the review of the terms of reference takes place annually. It's a commitment of the Health and Wellbeing Board to review the terms of reference. The terms of reference amendments that are contained within the papers that begin on page 13 of your packs are consequential amendments. The board, as many members will know, is subject to a Health and Wellbeing Board review, and we might come back at a later date to make more substantial amendments to the terms of reference. So, as you know, the board is a statutory board, a statutory committee and a committee of the council. So that's one of the, and the membership is determined by the leader in terms of elected members, and what we do is we annually review it to look at the operation of board and whether there's any tweaking we could possibly do. So in paragraphs 3.4 to 3.8 of your papers on page 14 and 15, set out some of the proposed suggestions to the way we might operate board going forward to tighten it up a bit. So it is proposed that an action log and decision log is introduced, and that will support the board and provide an audit of decisions and approvals that have been taken going forward. It will also help the board to drive forward and hold officers and partners accountable to commitments they've made at previous board meetings. That's at 3.4. As part of ensuring that, I seem to have gone on hold, Jenny. Hopefully members can still hear me. Fantastic, I'll carry on then. But as part of ensuring that future agenda items don't overrun and we give due consideration to all agenda items, we're proposing introducing a simple flag system to flag to presenters when their items are going to conclude, and that will ensure that we can consider all the agenda items that have been scheduled. And then as part of ensuring that the board drives forward the refresh of the health and wellbeing strategy that Joe Broadbent's going to be presenting later today to members, it's proposed that each meeting is used to cover 2 themes of the health and wellbeing strategy. There are six themes of the strategy which Joe will discuss with you later. And then finally, consideration is being considered to providing elected members with the opportunity to submit substitutions and nominate substitutions for when they can't attend, as is offered to other board members. So that is probably a quick summary of the terms of reference that are contained within your papers and the recommendations that are being made.
Thank you, Darren. Before I give you my many thoughts on the subject, does anybody like to add to that, question it, challenge it, give us their ideas? No? No hands up? Yeah. Councillor Ralph?
Yeah, thank you for that. Yeah, I think one of the, on item 3.4, the proposed action decision log, I think is one of the most important things that we can have now. It does increase accountability to tracking our progress right through via next year.
Thank you, Councillor Ralph. As chair, I've discussed a... Oh, sorry. Sorry, Ian. Do you want to go ahead?
Okay. I just wanted to reference the Health and Wellbeing Board review that's going on at the moment. So we had some money from the ICS to commission an external consultant to review the terms of reference of the board and board governance arrangements in the context of the new ICS at Mid and South Essex level. So that work is going on at the moment and will be brought back to board in due course. So I guess it's just to say we review these again in the context of the findings of Sean Lockwood, who's undertaking that work.
Thank you. Yeah, it's important to review, as you say. Also, it's quite an organic document, and the board should therefore be organic as well. So if we need reviews or to have discussions on it partway through, then I'm open to that too. Joe, you've got your hand up.
Thanks, Chair. And it may be that this could be picked up as part of that review process. Just a very brief comment on the terms of reference themselves under 2.5. It says sign off key commissioning plans, and I wonder if it's worth us just as part of the review thinking about the strategic nature of the Health and Wellbeing Board and how to draw a line between that and operational oversight. And it struck me that commissioning plans might be too detailed for the board. The board's consideration, and there might be another way to do that.
Yeah, please, let's explore that from after the meeting. Darren, I'll pick that up with you. Anybody else wish to say anything? No? Okay, so as chair then, I've discussed a number of changes to the operation of the board with the Secretariat, and that's been reflected in the papers. Before this board should really be driving forward action and holding each other accountable. Our job as a board is to scrutinise and challenge each other. we need to work collaboratively, sharing data and best practices, be critical friends and support each other. But ultimately, we all want the health of our residents to improve and to be as good as the rest of the UK. This is the year one of this refreshed strategy. It's a year of sharing what actions and decisions will be made to drive the health agenda forward. The strategy is our plan this year, and we now need to determine what we will do, how we will do it and when, and I therefore fully support the introduction of an action and discussion log to provide an audit trail of decisions and approvals that we take. Next year will be the year to start reporting the results of our actions. We have 6 domains, and as I set the agenda items going forward, we'll ensure we cover 2 domains each in 3 of our meetings. And I'm keen to ensure that future agenda items are considered as scheduled and given due regard. So in order to keep us on track, I also support the proposal to introduce Darren's flagging system. It's a bit like in full council, we get so many minutes to present, and when we're in our last minute or two, we get a warning, so we finish. And then that way it's fairer, everybody gets their allotted time for their reports, rather than one running over. So one of the first actions on the new action log, should it be agreed, is I would like to circulate, after discussing with officers and Darren, which domains we're going to tackle and areas of them very quickly, so that we can plan the year and everybody knows what kind of reports they will need to be bringing forward, if that's acceptable to everyone.
Agreed.
Great. I want to ensure that the board monitors health and wellbeing strategy, and so, as I've said, support the proposals at 3.6 and 3.7. I'm keen to ensure that elected members are represented at board, and that's why I would like substitutions, again, to help keep us quora in the room. And we all have daytime jobs as well. It can be difficult to be here, so if we can substitute members, that would be good. So it's recommended that members approve the amendments to the terms of reference as outlined in the reports and have been provided. So are members content to approve the recommendations?
Agreed.
Agreed.
So agenda item 6, Better Care Together Thurrock, the case for further change. We've got 45 minutes for this report, and I'm handing over to Ian and Kerry.
Okay, thank you, Chair. So I'll kick off and then I'll hand over to Kerry, and I was keen that Kerry present some of this because she has been absolutely pivotal and a huge amount of work in producing the strategy, and I thank her for that. I'm sorry I can't be with you in person today, colleagues. I still have COVID. Otherwise, I would have been in the room. I've got some slides, so I'm going to share my screen. If that will work. Can folks see that? I'm taking silence as consent because I know I can't see you.
Yeah, we can see it.
Thank you. Okay, so this is the essentially the integrated care strategy for adults dealing with health and wellbeing services. As you'll hear from Joe a little bit later in the meeting, it's one of the strategies that sits under the health and wellbeing strategy, and it's the delivery mechanism for goals 1 and 3 of the health and wellbeing strategy, and we're asking for that to be formally recognised today at Health and Wellbeing Board to give it that statutory status. You've got the main strategy, excuse me, and an executive summary in your packs. The main strategy, as no doubt you've noticed, is very long. We're kind of not sorry for that. I think it reflects our ambitions. It is in a sense, 6 strategies in one, dealing with our ambitious transformation plans to transform 6 different elements of the system around community empowerment, Chapter 4, primary care, Chapter 5, population health management, Chapter 6, integrated care within the community, Chapter 7, integrated care at home, Chapter 8, and our new vision for residential and intermediate care, which is in Chapter 9. The main strategy in terms of those 6 chapters are designed that they can be read independently, but there is a single model of care that is set out in Chapter 3 that actually draws all of those elements together. The strategy is based on really comprehensive engagement with all partners. It's been a year's worth of work in the making, a lot of engagement with frontline staff, and it's based on a comprehensive engagement programme with residents as well. The other thing I'd say is we're not starting from zero with it. So we've been on a transformation journey in Thurrock really for the last 10 years, and that's recognised both nationally, regionally and nationally. And we've got some brilliantly transformed services and innovative services already working to the principles set out in the strategy. If you think of things like local area coordinators, micro-enterprises, our collaborative communities framework, our community-led support teams, the work that Rita's starting to lead on the new model of care for the Collingham IMC, or the integrated primary and community care mental health model that we are currently rolling out in the primary care networks. The other thing I would say is it's aspirational, so not everything in this strategy is funded at the moment. We really didn't want to be constrained in terms of what needs to be done, and as funding comes online, we now have a plan in terms of what we will spend that on. The purpose, I guess, is to really set out our collective agreement as to what the next phase of our transformation journey is, as a set of Thurrock partners. And this strategy acts as our prospectus to the integrated care system. What we want to do is to negotiate a devolution agreement. We reject the concept that everything needs to be planned centrally. So this is kind of Thurrock's stall set out to the ICS. I think the final thing I'd just like to say is there has been an incredible amount of hard work by all partners that have gone into this strategy, and I thank colleagues from the CCG, from the NHS, from the third sector, and obviously across the council, because this really is a collective effort. Before I get into the strategy, we haven't got time today to go through every element of it. I thought I'd actually start with a story, because all great presentations should start with a story. And it's a story, I think, that demonstrates how the way the public sector in general has organised itself to deliver public service for the last 30 years through a theory called New Public Management that has resulted in a system that's fragmented, that consists of a series of individual teams and programmes. There's often very top-down, that exercises control through predefined service specifications and KPIs, and is ultimately incredibly bureaucratic, is one that's failing our residents and is causing what we call failure demand. Because we fail to solve residents' problems, we drive avoidable cost in the system. So this case study I actually witnessed myself, and when I became the corporate director about 16 months ago, one of the things I set in place very quickly was to go out and start shadowing our frontline teams, because it really gives you a different perspective on what's working and what's not working. So about 6 months ago, I booked a day with our occupational therapists, our OT team, and Gavin Beard, as a hugely conscientious manager, has organised this huge programme of activity for me to witness across the day. And the first bit of activity was actually to go out and visit with an OT. So this OT had received a referral to go and visit a 60-year-old gentleman he was living in a one-bedroom flat alone in Chadwell. And so I'm in the car about 10 in the morning with the OT. And she turns to me whilst we're driving to the flat, and she says, this has been a really difficult case because his underlying problem is alcohol addiction and mental health, but we just can't seem to solve the problem. So Owen, who was the gentleman in question, we'll call him Owen, had lost his wife 2 years ago, and he'd always drank heavily, but since her death, his drinking had really spiraled out of control, and he'd become seriously depressed. And he was actually drinking 5 bottles of wine a day. When we arrived at the flat, Owen was slumped in a chair, sitting in a pool of his own urine, and the only word I can use to describe him was broken. He was conscious, but he was almost completely uncommunicative. He was kind of grunting. He just looked so sad. He was clearly under the influence of a significant amount of booze, even though it was only 10:30 in the morning. The OT's job was to undertake a functional assessment of Owen to try and improve his physical functioning. That was clearly a complete waste of time in the circumstances that we'd arrived and found Owen. Because of his drinking, Owen's physical health and physical functioning had really seriously declined. And as a result, the council commissioned an external home care provider to help him with his mobility, with his washing, with his dressing. And we had 2 carers going in 3 times a day to Owen's flat to do that. What Owen needed was a single solution that addressed his mental health, that addressed his physical functioning, and that addressed his alcohol addiction. I don't know whether he'd been referred to mental health services. I hope moving forward he will get a really good service. But historically, I know what would have happened is that they would have said, go away and come back. Either you're not depressed enough, or because you've got alcohol addiction, we're not going to see you and treat you until you've sorted out your alcohol addiction. The support planner from our community-led support team was in the flat when we arrived, and it's safe to say she was at her absolute wit's end. So the 2 carers had come in and left. They couldn't move Owen out of the chair to toilet him. Owen couldn't be left because he couldn't feed or toilet himself. And what the support planner was trying to do was to get Owen into a short-scare day residential care home for some respite. And she had rang every residential care home in Thurrock, and not one of them would take him because they were worried about his alcoholism, and they were worried about where if he withdrew from alcohol that he would fit. So what Owen needed urgently was an alcohol detox in the community. So I called our alcohol treatment provider, and again, I don't say this in any way to criticise them. It's how we have actually commissioned them and set the system up. But they weren't doing home visits. They said Owen needed an assessment. They did have a mechanism to do urgent assessments, but in order to get an urgent assessment, we needed to do another referral to a panel that would meet to decide whether or not the referral was urgent. And that panel wasn't meeting for another 2 weeks. And in any case, Owen had no transport to get to their offices. And so the support planner was left with only one alternative, which was to call an ambulance and convey Owen to hospital. I said to the support planner, well, will the hospital do a detox, an alcohol detox? And she said, well, maybe they will, maybe they won't. Sometimes they do. And I said, well, how do you know? And she said, because we've been round this loop 5 times where we've conveyed him to hospital. He's sometimes detoxed, he's discharged, and then he relapses. And it struck me that what Owen and the support planner was faced with was a series of different front doors, all doing different bits of the solution that Owen needed. And the vast majority of those front doors had a threshold, an assessment, and a different referral pathway. And we think that historically, that we can save money by restricting access, go away and wait until you're ill enough. And actually, what this case demonstrates, I think, is that the reverse is true, where we don't intervene early and we don't intervene in a coordinated way. We're actually wasting money because we're not solving residents' problems. Ironically, the only door that didn't have a referral assessment criteria was the most expensive front door, which was the ambulance and the A&E and the hospital. And we've come up through developing the strategy with this concept of the need paradox. And the need paradox says this, that those with the greatest need, those with the most complex problems, are the ones that find it the most difficult to access a solution that works, because all of the elements of the solution are in different places with different waiting lists and referral assessment and thresholds. And I thought, how much has our interventions just on that one day cost us as a system? If you add up the time of the OT and the support planner and the externally commissioned carers and the ambulance and the A&E attendance fees and the hospital admission and the discharge planning, and I worked out you probably wouldn't get much change out of about £5,000. And yet we hadn't solved Owen's problems. And this, in a nutshell, is what this strategy is attempting to address. It's based on a concept called human learning systems, and it sounds very grand, but it isn't. It's really quite simple and straightforward. So we want to do human public service, and as I say, many of our transformed services are already working in this human way. But human public service starts from that recognition that we're all unique, we're all different, that there are many ways to be human as there are human beings, and that we all have different needs and strengths, and that we need to respond in a human way that recognises those different needs and strengths. And that the only way to do that is to start by building a relationship with the person that we are trying to serve, and then to design a solution that fits them, that's bespoke by design. To do that, we need to work in a strengths and assets-based way, and we need to start with what's strong and not what's wrong. We need to stop seeing people as a series of problems that we've defined. And we need to empower our frontline staff. We need to free them from the constraints of predetermined service specifications and allow them to respond in that human way. And as a result, commissioners have to give up the illusion of control. They need to stop thinking that we can centrally plan this, that we can specify everything in advance. Because when we do that, we end up with those series of front doors that Owen is faced with. In terms of learning, in a complex system, in a system built on the human relationships that we are working in, there's no fixed thing as what works. Because what works is always changing, and what works differs between different people. What may work to solve my mental health problem may be different to what may work to solve your mental health problem, because the causes, the underlying factors may be different. So learning becomes the key strategic action for how we manage our system. We need to constantly learn because the system we're working in is constantly adapting. And so there's this concept of commissioning from learning, allowing providers to flex contracts, building in service design at the start of contracts, in conjunction with residents, using data to learn, understanding and mapping what works constantly and what's working to solve residents' problems. And this concept of creating learning environments, allowing staff to come together to reflect a positive error culture, encouraging staff to report when things have stopped working, when the system's changed, empowering staff to innovate, to experiment, to try new approaches and to minimise bureaucracy. And then finally, in terms of systems, this is just simply a recognition that no single one programme or service solves residents' problems generally. What solves residents' problems is how the entire system interacts and comes together. And so if it's the system rather than programmes and services that produce outcomes, the goal is to produce healthier systems, because healthier systems produce healthier outcomes. And so to create a healthier system, you've got to bring all of the system actors together. And we've done this in Thurrock through our process called the theory of change, to really understand and reveal the scope of the system, to develop a shared purpose and shared values. And then there's this concept of system stewardship. So the commissioners move from specifiers and performance managers to people who look after the health of the system. So how can we encourage staff to collaborate in a more effective way, to trust each other, to innovate? So our strategy is based very much on this, and 12 transformational principles that are in your pack. I won't go through them all here, but an equal relationship with residents, that we want to design bespoke solutions, a preventative and a strengths and assets-based approach, that we want to empower our frontline to make decisions in the context of residents' lives, that we want to address health inequalities, that we want to cut bureaucracy, that we want a whole systems approach. And the way that we work ultimately needs to change, and we need to embed the learning of the services we have transformed. And again, there's some of the changes that are set out in your pack. I'll just finish with the high-level description of the integrated care model within the strategy. So there are, at its heart, I think, sits three key things. The first is our residents, and really leveraging the power of residents, leveraging the power of the people. So we want to have an ongoing conversation with residents throughout our journey. We want residents absolutely involved in co-designing and co-producing services with us and with the third sector. So that strengths and assets-based approach. We've got a huge opportunity with the new primary care networks, and that's set out in Chapter 5. So moving from a system of individual surgeries to delivering care through a network of surgeries to a transformed primary care network with greater use of a mixed skill clinical workforce. And Thurrock was one of the pioneers of this long before central government thought of this. Shared back office functions, and our new integrated mental health primary and community care model and an open dialogue approach. And then around that, we want to build, and there's 4 of these, one within each locality and each PCN, an integrated locality network. And Kerry's going to talk more about that. But allowing staff from different teams to come together to collaborate and to build those integrated solutions with residents. There are 2 key other elements. One is around home care and expansion of wellbeing teams, and the other around residential care and our new vision for a new residential facility at Whiteacres, about both intrinsically linked to the hospital. And I think the other 2 things to mention, one is population health management, which is the mechanism by which we want to transform the entire system from being reactive to being proactive and greater use of data. And then our integrated medical centres that will act as the hub to the spoke of the PCN and the integrated locality network. So I'm going to stop there and hand over to Kerry. Kerry, just let me know when you want me to click the slides on.
Thanks, Ian. I'm glad that you're going to be my Debbie McGee, because I've kind of seen something that says request control, but I'm just worried that we'll just lose all of the technology if I do that. So I think, Ian, yeah, if you can kind of do the tech bit for me, that would be great. And just say, my name's Kerry Armstrong. I'm the strategic lead for adult social care and health transformation, sitting in adult social care, and I've been working on this agenda for quite a while. So as Ian said when he first started, we've kind of been at this for a very, very long time. So I think this is the culmination of probably over a decade's worth of work and a lot of experimentation as well, because a lot of this stuff is new. And I suppose I wanted to start with a kind of paraphrasing a quotation from someone far cleverer than me. I think it might have been Einstein, who said kind of, do what you always do and you'll get what you always got. And I think that's kind of been our mantra across not just health and care, but possibly across public service and public sector for a very long time, that we kind of tweaked the edges, but fundamentally we haven't really changed the system, and the population around us has changed massively since we introduced the system in the 1940s, yet we haven't really kind of fundamentally looked and said, actually, what we need now is something very, very different, because people need something very, very different, and people actually probably today have kind of far more, as what we describe, complexities than they ever maybe did all those years ago. So Ian is kind of very, very kind of well set out the reasons and the rationale for why we want change. And Ian, if you can just kind of put up the rest that's on this slide, because I think this was one of yours that I actually stole. And just going back to Ian's first slide, where he was talking about actually the system being very, very fragmented, and us pushing people through lots of different doors, and they're not just examples like Owen, but they're kind of, I'm sure that all of us either had direct experience or know someone very close to us that's had direct experience of actually having to go through numerous doors to get what they want, when they only have maybe kind of a couple of different different things that they need resolving in order to get the solution, and sometimes they don't get that solution, or it's frustrating getting there. So this is what we've got in Thurrock at the moment, in terms of our health and care system. So we've got either things that happen across Thurrock as a borough. We've got a number of services and solutions that kind of take place at a sub-locality level. So that's what we would say around a PCN, and then we've got a number of services and solutions that are accessed on a broader footprint. So that might be across Mid and South Essex, for example. And at the moment, you know, as Ian said, people will have to go through numerous doors, front doors, to kind of access that. We make numerous internal referrals from one service to another, even within the same organisation, even within the same department. And actually then we have kind of numerous thresholds. And as Ian said, that's very much around kind of, is the person kind of ill enough or in need enough to access our service? No, if you're not, go back again. So actually we're not really resolving people's issues, and we end up kind of with a fragmented system, and actually numerous failure demand, which is kind of inefficient and ineffective, and doesn't do well to serve people in Thurrock. So if you want to just move on, Ian. So one of the key chapters and strategies really, which is in the strategies around how we're going to change how we engage with communities. And when I say communities, obviously that's a very generic term, isn't it? Because communities can mean a number of different things, whether that's geographical, whether that's kind of by kind of condition, or whether by things that people are are interested in. It's kind of vast, but we don't do that particularly well. We have kind of bespoke bits of engagement. We talk about co-production, but it tends to be with quite a small pool of people, and it tends to be on things that we want to know. So we kind of drive that process, and we tend to ask questions which really kind of we want to know the answer to, and then we're surprised when we don't deliver what people actually want or need. So actually what we want to do through the strategy is actually introduce a completely different approach to how we engage and empower communities, and also people that use or rely on us to actually have a good life. And what we're doing is we're actually testing this in, and you'll hear a lot about experiments, but we're actually experimenting in one area of the borough, Corringham and Stamford, to try and actually test and develop a new approach. And a lot of this is experimental, so a lot of this will actually change over time and evolve over time, and it's actually quite right that it does so. So what we're trying to do at the moment is actually identify the things that obviously people want to change, and the things that actually people are passionate about, but also kind of the things that people could also do for themselves. So it's not going out there and saying to people, well, what's wrong, what could we do better, but it's also about actually what are you passionate enough about to want to be involved in and maybe change. So we've got a raft of intelligence that's out there that we don't really do much with. So our frontline staff, for example, have conversations day in, day out with members of communities, yet they don't do anything with that intelligence, because actually sometimes the intelligence they gather is possibly outside the kind of the remit of kind of what they're there for. So it might be a housing officer that goes to talk to someone about, you know, a housing related issue, but whilst they're there, the person will tell them things that actually we would possibly really want to know about, that will really help us to develop the system going forwards. And the CVS have kind of developed an approach with a piece of software called Airtable at the moment, which is kind of helping to actually collate that kind of information, which gives us a far better understanding of what actually matters to people. And that's a really good kind of way of actually consulting or engaging with people on a day-to-day basis, as opposed to going out with bespoke pieces of work. What we're hoping to do with that intelligence is then kind of to develop what we're calling communities of practice. So small theme-based groups with people on things that they're really passionate about, so they can tell us what they want us to do, but importantly, and you'll see the diagram at the top, what they actually want to get on and do themselves. And actually, with that information, that helps us to develop or influence how we commission as well. So when you know kind of what people can do, what they're willing to do, what they want us to do, and what they need a bit of support to do, that changes how you commission, because actually you are engaging people from the start in actually what in the system that they want to have. So we're trying to kind of actually evolve and develop what that looks like with people. We're also developing in that area another community of practice across professionals, which means that professionals that are working in that area will come together, engage and hear what people have got to say about what they want, and then actually focus on how they can make that happen and develop the solutions that are very different from the solutions we've got today, which then again changes the very kind of foundations of what we've got in place. So we'll end up with solutions which end up with very different service kind of functions, and I say different kind of commissioning contracts, because actually what people want and then how we deliver it is very, very different. So that's work in progress, and we will actually obviously update as we come back to that, and as we're actually developing that over the next year to 18 months, because none of this is going to be a quick win, but actually what we'll do along the way is actually move forward so we can actually start to actually develop and input that change. So if you want to move on, Ian. And again, I won't go into this in any detail, but actually this just hopefully describes probably a bit better of what I've just spoken about. So I've talked about Airtable, about how that provides the architecture to capture the intelligence we know is out there, and the intelligence that we gather but don't do anything with potentially, and then actually creating those different PCN-based community engagement or community reference and investment boards. So starting with communities of practice, but then developing that further until we've got a means of actually people being able to decide what happens with the resources that we have, and actually how to use that to best effect, both with kind of communities doing things for themselves and actually them telling us what they actually want us to do on their behalf as well. So you have a very different kind of partnership arrangement, and power resting very much more with communities, whereas at the moment it rests very much with us and us telling people what they can have. So that's what we've got at the moment. So moving on to the next slide, which is around chapter 7, and again Ian said it's the strategy is very much about how we bring all of those disparate functions and services together to something which is far more a coalition and a collaboration, a collaborative approach, not just between services and professionals, but as I've just talked about, with communities and with people that are relying on us to actually live a good life. And if you can just expand that in until we've got all of the bits in there. So as I said, what we have is just a variety of different services that operate fairly uniquely at the moment, and often in silo. And as Ian kind of described, you end up having kind of numerous front doors that people have to go to try and get what they need, often not very successfully. So what we need to have is a situation where actually people can work together across organisational and team boundaries to actually better prevent people from needing kind of high-end services, so getting to them at that early stage, but also having solutions which work for people, so they're more bespoke. So moving away from this one size fits all, right, you've got this condition, this is what we can offer you, to actually what's important to you, what's actually getting in the way of you achieving what a good life looks like for you, right? How can we work together to make that happen? And when I say we, that's not just services, it's also the assets that exist within communities. So lots of people are actually becoming very isolated. So it could be around actually what can people still tap into to ensure that they don't become isolated and they can still connect within communities. And also about what the individual can do themselves. So is this something that they can give back? Self-esteem is a massive driver for people, regardless of what stage their life that they're in. And a lot of people still want to be able to give and contribute, regardless of what they need from others to live that good life. So what we're doing at the moment, and Ian described some of that, is actually carrying out a number of what we're calling again experiments. So actually, you know, with people like Owen, where they actually need potentially a number of different professionals coming together to actually develop that solution for them. Actually, we're tasking people with actually working with people like Owen and saying, right, okay, how do we achieve this? How do you move away from the threshold you have, the eligibility criteria, the cross referrals that we have, all the time that adds into the system and the inefficiency, to actually work with Owen. So Owen comes in, we have a different conversation with Owen, we understand what Owen needs as much as possible, and we actually can work together behind the scenes to actually find out how we do that. And actually, for a number of people, that might mean having one of those individuals that's involved with Ian, sorry, not Ian, with Owen as a name coordinator. So you have someone who is interacting with Owen to do all that coordination, rather than Owen having to interact with all of those different professionals. And that's the aim at the moment. And as Ian said right at the start, again, we've got a really excellent opportunity with the integrating medical centres coming on board, and with Corringham, to actually try a very different approach, with professionals being in the same place and actually offering something very different that's very coordinated and very integrated. And obviously, inevitably, we'll need people, specialists, professionals coming in to give specialist advice, and they may actually be providing that on a footprint that's beyond Thurrock, but we need to still be able to pull those people in. So actually, from Owen's point of view, it shouldn't matter whether we have services that sit within a PCN area, a Thurrock whole area, or beyond. Actually, because when we need someone who actually provides that support that's beyond kind of Thurrock, we should be able to, as professionals, broker that with that individual and actually bring them into detailing what they need to provide for Owen as part of that integrated solution. So that's the utopia, that's the ambition. And if we just move on one slide, I've tried to, this isn't, you'll tell this is one of my slides because it's kind of it's less whizzy, but basically I've tried to explain what I mean in terms of what I've said. So we have the resident, could be Owen, who might go through a front door, which could be the first contact is mental health. It doesn't matter effectively what front door they go through, but actually at that point, that person has that professional has that conversation with Owen and actually gets from Owen what else Owen might need in order to actually have a better solution. And that person then has to interact with the other services or functions that are needed to create that solution to come up with what the solution might be. And Owen is absolutely at the middle of that in describing how he wants that solution to be developed and delivered. So Owen isn't always outside of that bubble, but actually, you know, the important thing is that it should just be one front door that Owen goes through. And actually, in terms of how that approach should work, as I said, it should be one front door. We shouldn't be kind of doing cross-team referrals. We should be talking and actually coming up with a solution. We should be identifying and challenging barriers that stop us from doing that. We should be having kind of someone who's prepared to act as a coordinator if there are lots of different functions and services involved, and we should be working seamlessly to provide Owen with a better solution. So if you just want to move on, Ian. So just finally, I'm just going to talk very briefly, because we're probably running out of time, about wellbeing teams and our Chapter 8, which is around providing a very different integrated model of support in the home. And again, all of these chapters are very inextricably linked. So even though they're read by themselves, they don't act in isolation. So again, we've experimented kind of a couple of years, good 2 or 3 years now, with a couple of pilots around how we could start to develop a different approach to delivering care in the home. And that was because obviously the market was extremely and remains extremely fragile. It wasn't delivering what people wanted. It was very time and task focused, and actually we had real issues with recruitment as well. It wasn't providing a career of choice for people. It was very transient, and it was very focused on just on getting people in to do that time and task role. So we needed to change what we were doing. So wellbeing teams we felt was one of the options that we wanted to test, which did that. So wellbeing teams is very much around moving away from time and task to, again, having a very different conversation, identifying what matters, trying to actually work out a bespoke support plan for that person. It adds in variety, it's flexible, it allows people to use the time allocated as they wish. So it's not going in for 30 minutes every day, for example, to get someone dressed. It might be that we still have to do that as a task, but actually we might do it in a different way, or we might actually preserve some of that time to do something that person wants to do. It might be taking them out, or using that time to connect them to someone in the community, for example, or to have a different conversation, to stay with that person for a little bit longer to do something else. So it's a human model. It also kind of grows on technology. So we're trying to very much develop a new approach, which is not just going in there to provide a task, but actually going in there to prevent and to kind of keep someone well, and to provide a different kind of outcome. So the use of technology is incredibly helpful in this. You know, carers are able to go in, they're able to actually look for early signs of deterioration, they're able to flag those, they're able to work with with health and other kind of services to, again, pull people in. So actually, if they notice that they're going into Owen and he seems kind of a bit off today, then maybe they can do kind of a test for a UTI, and maybe then they can kind of contact their local kind of link nurse who will be kind of linked to that team, to actually kind of say, actually, can you just, you know, the reading's a bit off here, I think actually you might want to take a look. Whereas often we don't seek help until that person is really deteriorated. They might have had a fall, they might have broken their hip, they end up kind of going into hospital and then being in there for goodness knows how long, costing more, coming out in a very different situation and being far less able than they were when they went in. So it's about having a very different approach. We're also looking at moving those teams to being what we're calling blended. So again, in addition to doing home care type tasks, they may be able to do some of the tasks that commonly our nursing staff would go in to do. So maybe that's wound dressings, maybe that's kind of carrying out certain other tasks. It could be insulin, it could be a range of tasks that they can actually do instead of actually a nurse going in there and actually having numerous professionals going in, where actually one person could do some of that themselves and then liaise with others. So we're growing that. And actually, in terms of the whole hospital and discharge process, if there is someone from that area that's going in to hospital, could we link in earlier? Could we link in somewhere straight away? So immediately we are planning that discharge the moment we know that person's in hospital. And it could be someone we already provide support to. It could be someone completely new. There are a number of different approaches we can use. And actually, over time, we're going to try and expand the model so we can actually test more and more in terms of a very integrated approach to people. So actually they're getting what they need in their home from as far as possible from one professional. Or a limited number of professionals, and we've also started to do that transformation with our in-house provider team. So we started with 2 wellbeing teams, and now we've got 4 other teams who are working in the community to move towards that model as well, and to test that out. And what you'll see on the screen now are the different things that we're doing, different strategic actions that we'll be taking forward to test out that model. So actually, some of that will be about evaluation. And again, early evaluation was very, very positive about the number of hospital admissions we'd reduced, the number of GP appointments that had been reduced, and just the general improvement in outcomes for individuals that were being served by those teams. So we know it works. We just need to actually work out how we do this on a broader scale, and we need to work that out with our colleagues as part of this integrated approach. I think I'm going to stop there because I've probably talked far too much. I'm hoping that some of what I've said makes sense. Obviously, you'll hear far more about this as we go on, so I'm hoping that that will kind of serve as a good introduction. But I'm going to stop and see whether there's any time for conversation now.
Thank you, Kerry.
Ian, did you want to come in there before I
I was just thanking Kerry for. I think she explained some of this stuff much better than I can. So thank you for your presentation. I'm happy to take any questions.
Well, thank you, Kerry. This is the second time I've heard you speak on this subject, but in a very different way today as well. And your enthusiasm for it always astounds me, and it's very engaging. And I just want to hear more, because it is a very ambitious strategy, I know. Councillor Ralph, I know you've got a question.
Thank you, Chair. First of all, I want to thank you both for this very passionate and hard-worked document and strategy. Unfortunately, I was chair of HOSC on that day. I was off of COVID, like Ian, unfortunately. I've read it, I have questions ready. What I will say is that when you look at Owen, this will help Owen, but also it will help Owen 5 years before he got to that stage. Owen had many doors shut in his face before he got to where he was. This through meetings with GPs or other flags that were missed by many services. But if this works, this comes together, we will see so many changes in people's lives. It's one of the first pieces of documents that I've had in front of me that seems to cover everything. You know, you talk about integration, it's really integrated. There was one little thing I do want to pick up on, and we do have the police sitting in the meeting today, and that is where the police can play a role with identifying people that they meet on the streets of our local area that are getting into trouble, and there's clearly bigger issues going on in that person's life. I know we do have the street triage. I don't know if that's still operating. I know there's 3 cars running Basel and Brentwood. I don't know if that's used anymore. But for bringing the police more into this system as well, because it is through every access point that is available to us that we can get this right. And yes, there could be a little blockage with the GP's appointments, but there's so many other access points that we can look at and drag this together. But I think it's a brilliant piece of work. Thank you.
Thank you, Councillor Ralph, for your kind words and your support. They mean a huge amount to us. I'm sure I can speak for everyone on this call. I think the challenge you make with the police is a really, really good one. The essence of the strategy is to try and allow different frontline staff, professionals and the community to come together and just build relationships with each other around integrated medical centres, around integrated healthy networks. There's no reason why the police couldn't be part, and actually should be part, I think, of those networks. They're not explicitly referenced, you're quite right, and it's something that I think it's a really, really great suggestion, actually, that we need to take forward.
I can't see who's got... Kerry's got your hand up. Did you want to come back in on Councillor Ralph's question? Sorry, I can't see you on the screen.
Yeah, sorry. Yeah, I was just going to say that actually that's already starting to happen, and actually in some of the areas, both the community police officers that are allocated to particular areas, plus PCSOs, are already linking in with some of our talking shops, and that's been really, really helpful, because obviously, you know, people come to us and they don't just want to talk about social care, and actually some of the time they don't actually know what social care actually means. So actually having other professionals there that actually we can start to get to know, and also we can kind of actually get involved in when we're talking about solutions, is already starting to happen. So I'm really hoping that actually we've already laid the foundations to try and grow on that, and actually hopefully that will help the police as well, because I'm sure that they are dealing with people and actually don't know who to turn to as well. So I'm sure there are frustrations from their perspective, but I just want to add that there are really positive signals already.
That's great, thank you, Kerry. Councillor Lydiard, you've got a question?
Yeah, great report, good presentation. Really impressed with the whole thing. I'm a councillor in Tilbury, and I get probably 2 or 3 people a week, the sort of people that we're talking about that need sort of help, and I point them down at sort of various silos, homelessness, or community-led services, or community builders, or local area coordinators. And I have to say I'm a bit confused about who to point them to next, really. So, thinking about it, it would be great just to have one place and one coordinator to sort that person's problems out. Thanks.
Thank you. Stephen Porter, you've got a question?
Hello, Chair. Yeah, this might be an opportunity for me to introduce myself. Just to say, this is my first meeting. It's great to be here. I'm Steve Porter, I'm the Interim Alliance Director for Thurrock CCG. Formerly, Mark Tebbs was coming to this. I've now taken this on for a while at least, and wanted to say, first of all, congratulations to Ian and his team for producing a really extensive, detailed and thought out piece of work. The principles, as a social worker myself, I can absolutely sign up to, and who's working in the NHS can say that, you know, the CCG and the ICB going forward shares the ambitions that are in this document in terms of the bottom line for us, very clearly improving the experience and outcomes for our people in terms of receipt of health, social care and other services, universal services where people don't need social care and health services yet, early intervention and prevention, so that doesn't happen. But in the context of what's just been discussed, really interesting perspectives there. Fully support the approach of, you know, one front door. There are certainly people we know about, for example, who may have had, just as an example, you know, they had dealings with children's services, with children's safeguarding, and may not trust social services as a whole for whatever reason, for example, but may still have significant need. The opportunity here for other professionals to get in as a first point of contact and then provide appropriate services through their colleagues and supports is fantastic. And it's just one example of how extensive and far-reaching this can be if we can make it work. And I'm very confident that we can. There's a lot of work to do. But as I said at the ticker recently, that, you know, this has our full support. The principles are sound. The ambition is shared. And we will do our very best to work with the council, third sector, voluntary community, and all the partners to try and deliver this in collaboration with service users, the public, carers themselves.
Thank you. I think it's also worth acknowledging that some of your team, Stephen, have been intrinsically involved in the development of this, and Mark before. And many of our GPs, we had some really good engagement workshops with GPs, and they came up with quite a lot of the suggestions that have found their way into Chapter 5. So it really is a joint effort. It isn't simply council officers. And so thank you equally.
Thank you. Has anyone else got any questions? Jim?
Well, thank you, Chair. I'm Jim Nicholson. I'm the Chair of the Thurrock Safeguarding Adult Board, and I'd just like to add my own congratulations to the comments already made. A couple of quick points. This is going to be the perfect complement to the Making Safeguarding Personal programme that we've been progressing. So that's reached an advanced stage whereby the person that this is all about makes the decision about what's going to happen. They have informed choices. So a streamlined process like this is going to be absolutely fantastic, and it's really exciting, and I share the enthusiasm of everybody else. A couple of quick points that there's reference made to the need for colleagues who go to visit somebody to know how they're going to refer that on. And the referral pathways work is a continuing source of continuing focus for us, so that people who do see problems know actually who they can then tell. So that's something which we have made a lot of progress on, but there's still always further work to do. For me, I think the critical role here is that of the coordinator, especially in the early days, to make sure that they can access the services that are needed. I'm sure that's all going to be covered, but for me, when that is working seamlessly, we know that the job is going very well indeed. Thank you.
Thank you.
Councillor Ralph?
Yeah, thank you, Chair. I think when we look at this, one of the key things is people asking the right questions when they meet people. And I think that is going to be the key to success here, because you could have someone who is putting on weight, and until you ask them what's your lifestyle change? That's how actually, you know what, I've been down lately. I've not been going out as much. You're highlighting a mental health problem there, and we can then redirect those people. So our end game will be the complexity of problems will drop off. We'll be engaging them a lot earlier, and I think that's going to be the success of this, and the way it's designed is going to work. Thank you.
Thank you.
Does anyone else have any comments before I throw mine out there? No? You're absolutely right, Jim. The coordinator is going to be key to this, to making it work for that person. When I look at that Ian's slide with those gazillion doors, and you call them doors, but I think probably for your client, the resident involved, they're more like mountains that they've got to climb over than doors to open. And just sort of looking at your slide down to Kerry's slide and that working, because I so want this to work. Everybody does. We can all see the benefits for everyone. The stress levels of everyone involved, from staff actually having to take on those constant door knockings to the residents trying to climb in their mountains. Stress is up there as one of the things that we all have to constantly fight, because we know how bad it is for our health and well-being. And I think if you can nail this, we'll probably nail that one big time. It'll, 20% of the issue solves 80% of the problem. So, it's of benefit. And the more meetings I sit in now, as I've taken on adult social care, health and well-being, and I sit in our council meetings and HOSC, this one, the Mid-South Essex meetings, the updates with Rita and her colleagues, it's evident that we do need this joined up working. If we're ever going to make our money go as far as it can for everyone and actually improve people's health, we have definitely got to start working together. And for me, some of that means as well that underneath all of that is the reinventing of wheels sometimes, because I sat in a meeting recently where it was talked about the NHS were employing a company to find a way for them to engage with the community. And I'm sitting there thinking, have you spoken to council before you've engaged somebody to tell you how to talk to the community? Have you spoken to adult safeguarding? Have you thought about some of the things that they do? And we've got to start talking to each other first before we go and engage outside bodies to do it for us, because there's a wealth of data. I've seen Ian's face when he's not had any sleep from crunching numbers and data to get to this point. So it should be shared. We need to, I've said, we need to be working with partners. I want to thank Kerry and Les and Ian and all of the team. I know it's caused sleepless nights for you all. And early intervention, preventative care, more flexibility in the care packages, speedier changes. It's just some of the measures that we do need to be doing to ensure not only of greater benefits to health for residents, but to make our adult social care budget stretch as far as possible and help as many as possible. Because I don't know whether, I don't mean this in a disparaging way, but the NHS, you can overspend on your budget. You've got a legal bit of paper that says you can do that. We can't do that within council. We have to stick to the budgets we've got. So it's vital for us to be able to work with those other colleagues like the police, like Health Watch, like CVS, like the NHS, the Trust, CCG. I don't want to miss anyone out. I feel like the Oscars right now. But we do all need to be working together if we're ever going to make this work. This strategy underpins domains 1 and 3 of the new health and wellbeing strategy to be presented to members in the next item. It also facilitates the effective planning and delivery of Thurrock's innovative transformation programme across healthcare, housing and wellbeing services. I'm confident that this strategy has been developed in partnership and reflects the needs of place. It has been driven forward by the Thurrock Integrated Care Alliance, which provides the links between the Health and Wellbeing Board, emerging NHS structures within the new Mid and South Essex Integrated Care System. So it's recommended that members approve the Better Care Together Thurrock, the case for future change, as a delivery mechanism for the delivery of domains 1 and 3 of Thurrock's new health and wellbeing strategy. Are members content to approve the recommendation?
Agreed.
Yep. Great, thank you. So if we move on to agenda item number 7, the health and wellbeing strategy. This is the refreshed health and wellbeing strategy. There's a covering report and supporting documentation is provided at page 243 of your papers, and I'd like to ask Jo to introduce the item.
Thank you, Chair. The papers obviously give a lot of detail and the full health and wellbeing strategy report that we are asking the board to review and sign off today. So I won't go through the whole thing in detail, but I would just like to go through a brief slide set that will give you an overview of the content of the strategy and also the process that we've gone through to develop the strategy, if that's okay.
Yep, go ahead. I don't see anyone shaking heads.
Great, thank you. I'm just trying to share my screen. Yes, you can see that. So this has really been a partnership piece of work. It's taken over a year, well over a year, to get to this point. And I just want to start by acknowledging that and thanking everyone from across Thurrock and across sectors and all the residents who fed into this. It really has been a real joint effort to get us to this point. The vision for the health and wellbeing strategy is levelling the playing field. This was agreed last year with the Health and Wellbeing Board, and this vision very much relates to the national levelling up agenda, but also seeks to address those long-standing intergenerational inequalities that we see within Thurrock. So, for example, we have a healthy life expectancy gap within the borough between the most and least deprived groups of 8 years. And this has been quite a long-standing life expectancy and healthy life expectancy gap. So our vision is levelling the playing field, and we're seeking to level the playing field, not just at that high level about healthy life expectancy, but also across the aspects of health and wellbeing that feed into that high level outcome. We're looking to level the playing field across a broad range of areas that impact on an individual and a community's health and wellbeing. So in order to do that, we've divided the strategy into 6 domains, each of which addresses a different aspect of life that impacts on people's health and wellbeing. So these are listed on the slide, and I'll just quickly go through them. Staying healthier for longer, as Ian said, a lot of this is the detail for this domain sits within that adult health and care strategy that we've just heard a lot about, but it essentially covers what are often seen as those more traditional public health aspects of health and wellbeing. So promoting good health behaviours, so smoking cessation, supporting people to maintain a healthy weight, promoting positive mental health, supporting people who have substance misuse problems, for example. I should say that each of these domains, we had a lead for development of each of these, and we identified either an existing group or set up a task and finish group of partners and stakeholders to help us develop proposals for these domains. So the second domain is building strong and cohesive communities, and that was essentially drafted by the Stronger Together Thurrock partnership and draws very much on the collaborative communities framework. So the goals within that relate to the collaborative communities framework in terms of equality, empowerment, etc. It's very much aligned. The third domain is where a lot of the activity that Kerry and Ian have described around adult health and care sits. So I won't say very much about that, but essentially we have a high-level overview of some of the priority aspirations from the adult health and care strategy set out in that domain in the health and wellbeing strategy. The fourth domain is opportunity for all, and that's quite a broad domain because it takes a life course approach to this. So it starts with the best start in life, looks at opportunities for our children, whether educational and broader, educational opportunities for adults, access to employment opportunities, and more broadly to cultural opportunities. In terms of economic growth and employment opportunities, this domain links very strongly to the backing Thurrock economic growth agenda and the Thames Free Ports, and we're seeking to align the two, particularly around this domain. Housing in the environment is pretty much what it says on the tin. It's aligned to the housing strategy, the homelessness strategy, and also the developing local plan. So the built environment, but also the blue and green environment around Thurrock. And this is the key area where, as I say, alignment to the local plan has been set out. And then the final domain is community safety. This is aligned to the community safety partnership plans and focuses on some key areas where partners thought it would be really helpful to have additional emphasis in the health and wellbeing strategy on those very broad community safety plans. We've taken this broad approach, drawing on the evidence base around health and wellbeing. This diagram here is taken from Mid and South Essex Integrated Care Partnership Strategy, and it just illustrates that health and wellbeing isn't just determined by access to health and care services. In fact, that's one of the minimal influences. Only around 20% of the influence on an individual's health and wellbeing is around services. The built environment has an impact. Those health behaviours that I talked about, such as maintaining a healthy weight, have an impact. But the really big one is these wider determinants of health, such as employment, education, income and community safety. And so this is really why we've taken this broad approach, because it really sits and delivers against the evidence base on health and wellbeing. We've ensured that the health and wellbeing strategy is aligned with both the high-level council strategic approach and the Mid and South Essex Health and Care Partnership approach. The council strategy centres around people, place and prosperity, and there are three key strategies that are the main strategies for delivering on each of those. The health and wellbeing strategy is the key people strategy, and I've already mentioned the local plan and the backing Thurrock economic development strategy that lead for both place and prosperity. And you can see that we're working very closely with colleagues to make sure all three of these are aligned. It also aligns to the MSE strategy, which has a key aim to reduce inequalities and highlights creating opportunities, supporting health and wellbeing, bringing care closer to home, and improving and transforming services. So again, the approach we've taken is very much aligned to our wider NHS partners strategy. This slide just illustrates how each of the 6 domains aligns to the people, place and prosperity priorities, and 4 as the main people strategy for the council. 4 of the domains align there, but as I've said, we've got alignment to place and prosperity as well. This just illustrates what Ian has already described about how the detailed delivery in a number of other strategies, but particularly the adults health and care strategy that you've just heard about, sits under the health and wellbeing strategy. The health and wellbeing strategy is of necessity quite broad and high level, and the detail of delivery for all of the domains is captured in a range of other strategies. The Brighter Futures Children and Young People strategy, the adult strategy that we've just heard about, and a whole range of others such as violence and vulnerability, homelessness and community safety. So for each of the domains, we've got a page that looks like this. I won't go through them all in detail, but just to say we've identified 3 to 4 high-level goals for each of the domains. So those working groups that I spoke about earlier developed the proposals for those domains initially. We then went out to consult with both partners and residents during the autumn and winter of last year. We did an extensive consultation process, and then the goals and the details sitting under them were refined based on that feedback from the consultation process. So we've got our goals, we've identified who doesn't experience a level playing field in relation to that goal. We've identified key actions that we need to take to level the playing field. So this strategy identifies the high-level key actions, but we have a much longer detailed document, essentially an internal document for partners to support delivery on these actions. And we've also identified what impact we think it shall have. We've got progress measures aligned to each of the domains as well. So we've got one of these for each of the 6 domains. And as I said, we've got a much more detailed document for each as well. So finally, the next steps, we are asking the board to hopefully approve the health and wellbeing strategy for the next 5 years today. We have then a comms and launch plan that we've worked on with communications colleagues, both in the council, the NHS and the community and voluntary sector. So we will be seeking, after the full council meeting, to launch the strategy. It has been to HOSC, it has been to Cabinet, and it has also been to the MSC Health and Care Partnership Board for review before coming to you today. And I just want to finish again with some acknowledgements. This really, as I said at the start, this really was a partnership piece of work, and I particularly want to thank our colleagues in Thurrock CVS, Health Watch and Engage, who are really our front line of engagement with our residents during our consultation process. We absolutely could not have done this and could not have developed this strategy without them. So I'm really, really grateful to both our CVS and Health Watch colleagues, but also the residents and partners that took the time to comment on the strategy proposals. We had over 1,300 different comments on this strategy, which is a huge amount for a local strategy, and we did take account of them. So just to give you an example of how the strategy changed directly following the consultation process, quite a number of people and in different settings raised issues around digital exclusion or access to information and support through different routes. I think this was coloured to some extent by our experience during COVID, where a lot of things went virtual, and people were very concerned that not everyone had that same access to virtual support. So we've added in something around ensuring access to information, but also digital inclusion, which directly came from the consultation. Other areas that we strengthened were around substance misuse and around climate change, for example. So it really did make a difference to the strategy, the excellent work that both CVS and also officers did with residents and partners. And I'll stop there, thank you.
Thank you, Jo. Has anyone got any comments or questions? Ian, your hand went up very quick there.
Thank you, Chair. This is a absolutely critical document, obviously, for us. It's the highest level people strategy for the local authority, as Jo's alluded to, and obviously it's the highest level strategy of this board. It has statutory status, so the new ICS must have due regard to its contents in their commissioning decisions, and effectively it provides a framework, I think, for this board that allows the board to hold each other to account and wider partners to account for collective action to drive measurable population health improvement. I speak from some experience in saying, having been intrinsically involved in the previous health and wellbeing strategy development over 5 years ago, that it's quite a thankless task to try and develop these. This strategies need to be broad in the sense that the again, as Jo has alluded to, the fundamental drivers of health and wellbeing are incredibly broad, but it also needs to be specific. Otherwise, they can read as kind of motherhood and apple pie. And I think Jo has actually managed to pull that off really effectively in this document. And so I'd like to put on record my thanks to Jo for her brilliant leadership of this process. That isn't not an easy one to pull off. My other observation is that producing these things is often a thankless task because everyone has a really strong opinion about the need for their specific area of work to be included within it, but those opinions don't always align, and so one has to try and mediate between them. and take account of the engagement process. I wanted to echo Joe's thanks to Healthwatch, who and CVS, who have been the most brilliant partners. And I'd like to put on record my thanks to Darren Christensen. Darren works quietly and efficiently in the background, but Darren really did coordinate and lead a huge amount of the work to support Joe, particularly around the resident engagement, and we couldn't have done this without Darren's extremely diligent hard work and professionalism throughout the process. So my personal thanks to Darren as well. I think it's a really good document, and I'm really, really keen that we support it today.
Thank you, Ian. Sometimes I think, I mean, you're absolutely right. Everybody does need to take due regard of the health and wellbeing strategy, and there's a statutory requirement to do that. And when we talk about accountability, we have to have accountability for the actions we take against residents. And I know sometimes as councillors and members, we're that voice of challenge because we've maybe got that front with the residents, and it comes across like maybe like we're talking to children in the classroom that feel they're getting their homework marked, and maybe we're enthusiastic with that and critical with it. But I'd like, going forward, I'd like that to be seen as critical friends, as a partnership, that we can all speak openly, because unless we speak openly and challenge each other and really put those difficult questions out there to these tables, to these experts that are all in the same room, we're never going to make this change and make these strategies work. And Joe, I know you've had some real headaches with, is this enough? Is it too broad? Is it, have we got enough there? But that's why I will always be your advocate of saying there's over 140 pages and there's like a gazillion strategies underneath that feed into all of those strategies to make that overarching one work. So, yeah, I agree with Ian. I think you've got it just about right. Councillor Ralph, I know you've got a question.
It's more of thanks. When I first heard this, we were doing the consultation, and we did have some engagement problems that time. Obviously, COVID was coming on, with learning a lot from that. And Healthwatch, CVS, and apparently Darren has come in and really done a good job of engaging with that, and we've learnt a lot from that. Joe, thank you for this, and Ian, all the work that's been done on this. This is, as Ian said, it's a key structure of what we're doing. Being as it is such a key thing, the only concern I do have, and it's more about the officers' well-being and the people running this, is that it's a lot of work. Managing this is a lot of work, and the overview of it to make sure it all comes together and works. And I guess I'm going to say, I hope you're prepared for the work that's coming your way to manage this, because we're bringing everything together now. The overview of this is going to be quite key. Thank you.
Leah?
Just to echo everybody else's thanks, and to say on this agenda today, probably the best graphics and charts I've ever seen. So thank you. I don't know who was responsible for that.
That'll be Ian and Joe and the team and Jenny and Darren and just about everybody that's not a councillor, probably, because we still don't know how to operate the system. I'd actually maybe like to hear from some of our partners that are going to be, like, on moving forward. There's going to be a new structure with the ICS and how things will work, and I'd maybe just like to hear how you see the strategy being taken due regard of within that, and what you think of it.
Shall I answer that one?
Yes,
I think
please.
as the incumbent going into the ICB and the ICS. Well, absolutely. I mean, let's be clear. I think there's a lot of the new legislation, the Health and Care Bill. Really, the Health and Wellbeing Board is untouched largely by that, and it remains a very solid foundation as a council committee. with its own constitution and reporting to the council structures and the governance. So really, it's a question of how those are the new organisations and the new structures in the NHS will work alongside the Health and Wellbeing Board. And I think it has been stated in statute that we have to give very important cognizance to the Health and Wellbeing strategy and to the Health and Wellbeing Board and its structures. And we have to make sure that we don't duplicate its work, but we work to complement it, that we work to build a true collaborative partnership. And I know these sound just like words at the moment, and actually a lot of them are just written down in legislation and guidance. But I've been here a short while now, and I do believe there is a real willingness to try and make it work in Thurrock. Thurrock is further ahead than some places I know of in regard to partnerships and its forward-thinking approach to really working in co-production with members of the public, our residents, our service users, carers, patients, whatever however they describe themselves. But the Health and Wellbeing Board is a given, and the Health and Wellbeing strategy absolutely will inform our thinking in terms of our policies, our procedures in the ICB, working to complement those that already exist within the council as part of this board. So I'm very, very happy to support the strategy as Joe has described. Absolutely sign up to the principles that are in there, and I believe wholeheartedly that we can work together. Yes, there'll be a few teething problems for sure with new structures, there always are, but I do think we all want better experiences and outcomes for our residents in terms of those things, social care and health and all the stuff around that. And I think it's not just about the NHS and the council, it's about Health Watch, the voluntary sector, and the third sector as well, coming together to deliver on that. So it's absolutely welcome from our perspective, and we will do our best to produce good results from it.
That's great. That's music to my ears. Thank you. Could I ask maybe Terry Fisher, you're here representing Essex Police. What do you think of it, and about the new focus on crime and antisocial behaviour?
Yeah, sure. I mean, look, I'm representing Maren Barnett here, and the main thing for me is taking away the proposals here, and I'll make sure that she's aware of what exactly we're looking to achieve. But look, let's be clear. In my role as a district commander, I'm very well versed in how well we work together in Essex Police and Thurrock District Council. It's a very unique partnership, and I can say that as well from my operational ability, where I've worked in many different districts up and down Essex, and Thurrock is very unique. It's an ambitious agenda. It's correct. It's right. But without sounding overconfident, we've got the right team around us to get it done. I think that's already been highlighted as well. We've already got some things already set up. The push and drive around ASB and crime, etc. Yeah, there's some things that we're recognising and working on other forums as well, which could be of benefit maybe to this as we move forward. But I suppose my commitment is this from Essex Police, is that we're here to support and really want to work as collaborative as possible with all partners here in getting something done what really has got. And let's be right, it's about doing some good, and I think that's what it is. So nothing more than what's already been said. Certainly I'll take away any feedback that Maren Barnett has and pass that back, unless she's here herself at the next meeting, which I'm sure she will be. But yeah, that's certainly where I'm at with it.
Thank you. Yeah, I think it's evident we do have some really good relationships between us all and working together already. Like I say, in order for this to really work and for it to be collaborative and for us to build on this, we've got to build those personal relationships a bit as well, and not see people in a bad light for having disagreements within this room, if you like. One thing as we do as members on the political side is we go into the room, they're all our colleagues, some are our close friends, but we go in that room and we have a proper bun fight, and we might say things to each other that we regret afterwards, but we all know that it's said with passion to move forward in the right direction. and whatever is in that room stays in the room, and we come out and we talk to each other afterwards. And I'd really like us to be able to do that so that we can get this challenge and this those difficult questions and not be offended by them, and like move us all forward, because I think if there's going to be a stumbling block, that's where it's going to be. And we've got some real good stuff here to work on. Rita, I'm going to kind of give you a last word on it, because you're the face that I can see on the screen and recognise as Mid-South East Essex.
I thought that was actually because that's exactly what we need and what we're working through. I've been here 2 months, and actually, obviously, my role it clearly is about maintaining, building and working with that level of trust and partnerships across the whole of place, but also teasing out tension, any complexity around system as well. And that's why I was smiling, because Stephen and I have already had some of those conversations, and we've had that level of honesty and frankness to kind of ensure that place is priority. And actually, everything that's been said this morning, and there were a few times that I wanted to just go, yes, that's right, we've kind of got these stories, but I didn't want to interject because I'll just keep talking and you'll get used to me. I'm a storyteller by cast, if that helps. So I do have to stop myself, but we are experiencing exactly these stories right now. We are working through those challenges, whether it's between professionals, communities and professionals, or actually at place or at system. I've been here 2 months and we've done all of that already. But our bottom line is actually about the trust, and actually not leaving the room or space until we come up with something that actually works for Thurrock. So absolutely appreciate the stories that we have been talked through this morning and our approach. And I have to say, for me, the health and wellbeing strategy is so clear and simple in how we've got to get this right. It's much, much easier than a lot of strategies in terms of actually the language that's used within it. It's very clear cut. So thank you to Joe and team, and definitely the support you've had around it from Darren and colleagues as well.
Thank you, Rita. And sort of like putting it out there from myself, of if it's any help, you can all think about it, is one of the things I was asked to do for HOSC actually was to talk about my roles and responsibilities as a councillor and as a member and an elected member, because it's very different to yourselves. So if anybody thinks that might be of help for me to talk to them or their colleagues and share a presentation on why we do what we do and why we behave in the way we do, maybe, I'm more than open to that and to be questioned on it.
I think that would be really valuable, actually, and I wonder whether we can arrange some opportunities. I think particularly with some of our frontline staff as well. I'm just thinking some of your teams, Rita, and put it in there.
Absolutely, and in fact, so this has been really helpful, hasn't it? Because again, it's that level of honesty in saying, for me, it's the first time working in this space and actually being employed by local authorities. So I'm often asking Ian and Darren and colleagues questions about how the approach works, how we make, how I sort of learn the rules, the new rules and the togetherness rules. So actually all of this would really be helpful for me and for frontline staff actually to see all of this knitted together, and that there isn't that difference. So would value that tremendously for me and for teams, frontline teams.
That's great. I mean, I'm more than happy, and I'm more than happy to do it as many times as you need. Perhaps we can coordinate that through Darren and Ian, and
yes,
I'm happy to take that forward. Has anybody got any other questions or things they want to say before I carry on? No. So basically, what I want to say is that I understand that a communication plan is being developed and will support the launch of the strategy as planned next month. It's not being provided in the final papers and will be circulated to members virtually for comment shortly. The strategy will be made available on the Council and Partners websites. The strategy is the statutory responsibility of the Health and Wellbeing board and provides focus on place, as I've described earlier, and I'm keen to ensure that the board drives forward its implementation and continues to improve health and wellbeing outcomes for the people of Thurrock. It's recommended that members review, comment and approve the final draft strategy at Appendix 1. I feel that we have kind of like reviewed and commented on it, and sometimes I think that's missing, so that's great. So sorry, but I might just drop you in it again in another meeting and just ask you for your comments if they're not forthcoming. We need to consider the proposed domains and goals, review, comment on and approve the formats of the accessible and easy read versions on pages 249 and 287. And Joe, I thought they were great actually. That large print, those pictures were really good. And the one with all of the diagrams and everything taken out of it, I love a spreadsheet. I'm on Ian's team here. So that for me, I thought, oh, goody, I've got an easy read version. That's excellent. Members have previously approved the consultation report and are mindful of the size of the members' bundles, and the consultation report was not attached to today's papers. We need to agree to review, comment on and approve the plan to launch the strategy as per the communication plans which will be provided virtually. Are members content to go ahead and approve the recommendations?
Agreed.
Agreed.
Great, thank you. I didn't hear any no's there. So that, oh, we're closing and we're closing early, are we, Darren? Do I get points for that? Has anybody got anything else, any sort of like other business that they'd just like to share out there? No? Okay, well then, thank you all for your attendance. I'd like to close the meeting and thank everyone for their contributions today. Thank you.
Very, very well, Chair.
Thank you. Bye.
Thank you.
Good afternoon.